an assumption that you may not know much, but that may be false. Many of you may have medical backgrounds and others, and I apologize up front if I'm too simplistic, but it's just to make sure that I communicate as well as I can. Tuberculosis in the United States is relatively limited. It's not widespread. We work with doctors, hospitals, laboratories, anyone who thinks there might be tuberculosis reports that information to the health department. What the health department does is then try and work with those doctors to determine, yes, it is tuberculosis, or no, it's not. And a large percentage of our reports, suspicions, turn out not to be the case. And that's good. That means our doctors and our medical community are giving us things that they think might be tuberculosis, not waiting until it's too late. So we then, once we know there is a case of tuberculosis, and let me back up, even when they think there might be a case, we make sure that whoever they're worried about does not be around lots of other people. They're in a sort of a house quarantine, if you will. They don't go to work, they don't go to school, they don't know anything until we know and their doctor knows whether there's a tuberculosis true infection or not. And when that is confirmed, when it is confirmed, what we do, and to be fair, we sort of work it at the same time, we've already asked the questions about where have they been, what have they been doing. That is what's called a contact investigation. We look and put a wide net out and we ask who has been around someone for hours in a closed environment, in a classroom or a room, shared room, living in the house, things like that. We start working a list of who we think could have been exposed, could have. Most of the people that we have on our list and we go out and check don't, or their test and their follow-up shows they were not exposed. It is actually very hard to contract tuberculosis. The way tuberculosis is spread is that someone who has it in their lungs will be coughing, and they will put it into the air, and those people who share that air for a long period of time, hour is kind of our minimum target, that you would breathe that in. If you're actually outside, the sun kills tuberculosis. Remember in the olden days you probably saw where they'd send people out west to go recuperate and be outdoors. Most of the hospitals used to be wide open and airy. And a lot of that was to prevent tuberculosis from spreading. I mean, tuberculosis was very common in this country. It is not this here. So what we have done here is we were notified of a possible case. It was confirmed. We then worked to find out where the students, where they, he, she, I don't know, I'm not even, spent their time, so we could come up with a list of recommendations for parents to say, if your child was in this vicinity for this period of time, we are going to facilitate, we recommend that they get a test. We are not against testing other people. In fact, we believe, and I would strongly support, people getting tested. Many times the doctors automatically do this if you have at a certain age, if you've been traveling, because tuberculosis is much more likely to occur in other parts of the world than in States. What the test will do is demonstrate if the child, in this case, has been exposed. It doesn't mean that they are sick. It does not mean that they are contagious. If I just tested every one of us here, it wouldn't surprise me if about 5 to 10% of us would have a positive test. That's a general estimate of the United States population. If I changed this and we were all in certain risk factors, people that have been in shelters or been in jails and others where there's a lot of close-knit and close contact, that goes up. But in the general population, it wouldn't surprise me if that were the case. But no one here would be infectious unless you were sick, coughing, and looking under the microscope of what was coughed up, they actually visually see the organism. That's the definition of contagiousness. So a positive test, if it happens to come back for what we're looking for, in no way indicates contagiousness or illness. It indicates that the tuberculosis germ might have gotten in, and if it is, we have medication that will eliminate, cure it, and so that there will not be any concern later on. Even if someone tested positive and they said, I don't want the medicine, I don't want treatment, 90+% of the time they're going to live their life and never develop illness and the sickness of tuberculosis. They won't come down with active TB. Because the body's immune system can keep that in check. Increasingly, as we get older, or you may have even read some of these commercials for these new drugs for rheumatoid arthritis, they all say, talk to your doctor if you think you've been exposed, because they're going to run this test before they give you those medications. But the normal, healthy people will, if they get infected, 90+% will never develop active illness. We recommend, if you do test positive, to take some medicine now so that we don't even worry about that additional, that 10%. I don't have a crystal ball. I can't say which one of you would be, become sick versus not. So that's sort of the logic. We will work with your physicians. We will work with anybody that you feel medically you want to involve in the care of your child if any test becomes positive. So let me stop there and open it up. I think the questions help each other, so don't be shy. I don't think this group is. But yes, ma'am.
Can you just have more information on the patient for her time and when, and what's the likeliness? Because I get the feeling that, okay, kind of calm down, everything's going to be okay. But the letters like, it's highly recommended that you get tested. So
yeah, if you right, no, the letter. If you did receive the letter, we have not everybody in the school is going to get that letter, and that's because we've already looked specifically at the classroom schedule, interviewing and discussing. I do know that there was minimal, if any, real symptoms, which does happen with tuberculosis. And part of that is because the doctors are very alert. And so the patient in this case had what I would call an unusual, atypical presentation. Not a lot of coughing, not a lot of fever, not a lot of things that would have said, that they would have been putting tuberculosis in the room. But that said, we have gone back and felt that I think the October 29th date was the one, looking back, if there was even the small possibility, that would have been a date that we want to make sure we are very focused on who was around and things. And of course that went all the way up to the Christmas or the holiday break, and then once we were notified, the child has not had any, has not spent any time in schools. So what's important in most cases with your question is not who they are, but what kind of symptoms do they have? What did their x-rays look like? How angry, if you will, was the tuberculosis? And in this case, it was actually quite mild. In addition to that, what's most important is, you know, what they did and where they were and who was around them. And we've got that information. So I hope everybody understands that we certainly are not withholding information that would be needed to take actions. But we do always have to try and at least be respectful of people. And but as I mentioned to anybody, if there was a need to know, you would have all the information you need to know. I saw a couple of yeah, that's if when we look back and the person presented to the doctor, we'll ask them, when did you start when did you not feel right? Was there anything? And we identify that sort of ballpark time and use that as our point to define when the period of time where potential, and I say potential, infections could have been spread. So we go in our, yes, the physician. Yes. Chest pain. Well, chest pain, actually, again, as I mentioned, is a very unusual, and when it presents in others, not this one, but in our experience, is more related to low contagiousness. It's the coughing, the night sweats, the fevers, all of the others, the weight loss, they call it wasting. That is most directly related to contagiousness. So the fact that that was the primary symptom, and I'm not going to speak to this case, but I would take in general, as a doctor and working with those doctors, that puts things into a lower risk. But it did not change the fact that we still used our timeline to say, okay, the symptoms started here. Here is the date that we want to be certain, as much as you can be, to say this is the date forward. We want to be very focused, and we want to know where the person was, what they did. Over here, and then I'll go over here, and then over there.
I might have missed this, but when was the last date the student was in school?
You know, it's the last day of school, spring break, or not spring break, Christmas holiday break. December 19th. I used to know that when I had kids. sorry, I'm missing.
She wants to know why we're waiting.
The day that they have to be tested for school is February
Oh, sure.
17th.
Oh,
So we were running live, and that's the doctor, he said, and I guess it's 6 months. That was-
yeah. The type of test doesn't directly test for tuberculosis. It tests for the body's reaction to it. It takes 6 weeks or so for that test to be useful. And so if you don't, you're waiting too early. If it comes back negative, and we say, oh, wonderful, but in fact the test doesn't work in that setting. Does that make sense? I mean, and I would happy to, your doctors, give them my number, I talk to them all the time. I have a, oh, here.
So can we assume that if we got a letter for our child to be tested, that obviously when they were in a class, that kind of exposure, I mean, what
That's the most
type of
common. I
exposure?
think they're probably, again, we can include people who perhaps have after-school things close with them, something that in our talking created that condition where somebody spent a prolonged period of time in an enclosed space with that person, whoever they are. That's the way we do it all. Now, so
So it could be as much as being in a classroom or being in the lunchroom with 300, just having lunch with them with a couple other students.
again, I think each case, if somebody ate lunch every day at the same time, the same place, with the same people, that might be different versus the entire lunchroom. Does that make sense? But the classroom becomes the most consistent means, not only because of the time, but it's a closed space. You're there. The bigger the room, the bigger the environment, the much less likely there is. Active tuberculosis cases on airplanes. What's the hours?
8 hours.
8 hours on an airplane to be exposed. 8 hours. So what we'll do is we'll look at somebody and ask them how much time cumulatively to be safe. It's not a highly contagious disease. Wait, I lost track now. Somebody.
You talked about the skin test. Can you talk about the blood test? And can that be done earlier than the skin test?
Actually, no. What the difference is, the skin test has a little different interpretation. You know, you have to read it, you have to feel it. It also tends to what we call cross-react with other types. Mycobacterium tuberculosis is the one of many types of mycobacterium that we live in that are in the ground, in the water, that don't cause tuberculosis. But the skin test, can react to those. So you could get what they call more false positives from the skin test. But it is the best, or it is a very good first shot screening. If we are worried, when we're worried that we will never see the person again, and we do this in homeless and shelters, we often use the blood test because we don't get them back, you know, if we have to find out more. So that test is helpful in that. So they work, they work similarly, and in certain populations we'll prefer one over the other, if that makes sense. I'll walk this way.
When did you get notified that the student may have TB?
I want to say, and Jill, correct me, I think it was the first question came up January 13th.
What was the question?
She asked, when was the potential, the worry that the person might have tuberculosis raised to us? When were we notified? January 13th. Is that correct? Yes. So that's the first time when people come up, and so what we do is, from there, just like I said before, we talk with the doctors, talk with the people. We ask, is the person, what kind of work did they do in their job? And we ask and have them stay at home from that step forward. Sometimes, and we know when we get called, and we wish we'd called earlier, they'll call us after the tests are already definitively proven. So we now have to go back. We don't even get that starting point to do that initial quarantine, if you want to call that. But in this case, we had that ability to keep the the person wasn't around anybody while the doctors worked up a very unusual case. And then I think it was the very end of last week, Thursday or something, that they confirmed, yes, they know it's tuberculosis. And that's what triggered us to begin the arrangements, the asking, exactly who do we need to communicate with. We met with the schools to get the preparation, and this is the continuation of that process.
I have kind of a two-part question. I apologize if I missed part of this. One is, if we know that it's contagious via airborne, and we know that it's not highly contagious, maybe like a cold or some sort. However, sneezing, coughing could cause that. Not everybody covers their mouth or whatever when they sneeze, cough. So you have this child, teacher, whoever it is, walking around the school. Why isn't the entire school being tested? And second question to that is also, if my child were to come back and be tested as, positive for exposure, what have you, what are the effects of the other family members in the household? Because particularly in our family circle, we have one member with cancer that's withgoing treatment, and another one with COPD.
Let me try to answer the last one first, because it may have been right. A positive test, if it's found, means that there was an exposure. They're not contagious, they're not sick, they have no risk to anyone else. Working as a doctor, my skin test became positive. I can't forget when. That happened to a lot of doctors. And so basically you get checked, or you are asked to keep tabs on things. Or in my case, I took the medicine. But my skin test will still now be positive. But I was never contagious with tuberculosis. So no one else in your family would be at risk if, as a result of our testing, somebody becomes positive. Why?
How? Why or how?
Yeah, because the way it is an illness is that it gets in the body, and the body's immune system really locks it up, puts it in jail. Back in before the antibiotics, in the 50s or so, the number of people in the United States with skin test infection with tuberculosis was extraordinary. 30 or 40% of the entire population. Yet, very few people actually became sick. And to be contagious, you have to be sick. You look at what they cough up under the microscope, and you actually can see the bacteria. So a skin test positive is an immune, it demonstrates that your body actually, it's a good sign. It tells your body is working and has reacted to the introduction of tuberculosis, and it's now in check. And at that point, as I mentioned here before, we recommend people to get treated, but some choose on their own not to get treated. We wouldn't isolate them, we wouldn't worry about them unless they became sick. the first question was, why don't we just test everybody? Well, the facts and the experience we've had across, hundreds of years of dealing with tuberculosis, so if we know with very good confidence the likelihood of potential of exposure, we then say we're going to still test more than just those. Or we're going to offer that testing, I should say. And in my experience, and Jill, you've been here a little longer, we've had 2 or 3 schools that we've tested over, and we did the exact same thing. The test almost always came back very low. I mean, the percentage of positives, very low, probably had nothing to do with the individual case. So we know a lot of experience from this. But I would also say, and it does not matter if it was this school or any other time, getting a tuberculosis test from your doctor is not, it's good medicine. And if you live in certain, areas, or if your family is from another country where tuberculosis is more common, the doctors would test, even when they're fine, because they just know there's a chance. So the test itself is a good thing. What we're using it from a public health standpoint is to react to a potential threat, to make sure that there is no other spread to anywhere else, and that's what we do.
My question was, it's my understanding that some students receive letters stating, we recommend you be testing. Other students, we recommend you not be testing at this time. So does that mean if the letter was not to be tested, that you're guaranteeing that our children were not exposed then to this other child that has been contagious?
Well, I think what I think we're trying to say is that based on everything we know everything about the situation, about the bacteria, that the only people that really have a quantifiable risk are those that we are asking letters and recommending testing. I don't think any doctor can say 100% negative, but we also know that based on everything we've ever done, this generally includes many more than, we test a lot more than we should. It sounds that's not right. We test a lot more than that are really likely exposed. We try to test more than we should. Does that make sense?
So there's a possibility that our child maybe was exposed to someone who's going to be tested soon, and you don't know that.
Great
because
question.
it trickles down.
So if somebody else becomes positive, we identify them, and through that, which would be unlikely in this case because they generally haven't had time to develop the risk to be, but if we did, we'll check an x-ray or look at them and talk to them, and if they say, yeah, I've started coughing, then we start all over again. I mean, or we ask that person where they've been, and that could change things. That's why this is a beginning of an investigation. In addition, we know if we're going to test who we think are the first round, if you'd say, and I told you the 5 or 10% is not, is pretty normal. If it comes back that we've got 20%, if we have a high number, that changes. We have to rethink, because we don't expect to see that many. And if we did, then that, in any other circumstance, we would expand the circle.
So is it best to just say, go ahead and get tested? Because during the holiday season, of course, I could say my child coughed. We all did. It's the nature of that season. So does the symptoms come and go? Could it be something that they had and then
You
they're
will not,
okay? Or
you don't get, to be,
because this student was symptomatic, obviously, they didn't just test positive, they were symptomatic
well,
because they're contagious,
yeah,
correct?
and the symptoms were very unusual and typically fit into what we call the lower, less likely to be contagious. But they were symptomatic.
Like a cold,
Yeah.
for instance,
Well,
maybe.
this one, in this case, it wasn't even that. It was really, it hurts right there. I don't know exactly that's where they were, but yes, it was a type of symptom that is not, that probably, why working with the doctors, it took longer than normal. If somebody's coughing up things in sputum, it only takes a day or two to get the tests back. I mean, they're pretty quick. So when it takes a while, there's generally, it's harder to find, and that means there's less tuberculosis being spread.
I have a question that goes
Yeah.
with that. Because it wasn't the norm, wouldn't it be better to be a little more, cautious? Because
Well,
it wasn't
if-
the norm?
Well, no, but, the normal is, normal can, things that are not normal can be bad because they're not normal, in a sense of someone who presents and their symptoms or how they were ill is associated with more risk of spreading versus less normal because they had less. So they're in the less. We're actually doing the way we are approaching this and the way we would ask the questions, we're assuming, even though they had very minimal symptoms of this, we're still doing it just like she was coughing or, so we're doing it just like if she had all the symptoms, they had all the symptoms to be in that contagious category by how they were sick. So to do more beyond this,
Well, my point was, could there be other children that are affected, contagious, and not have symptoms, and they're walking around? Not every illness has symptoms,
yes.
or known symptoms
yeah.
to that person. Like a pain here could be, I got bruised, I got hit, student hit me.
It's a fair question. I mean, if you talk to us or anybody before this, could any illness, any complaint, might be something? Yeah, could be. That's why parents like you, doctors, you go take your child, you get asked, you do what you need to do to find out what's wrong with them. And in this case, that's what happened. And that's when we start doing our thing. The tuberculosis is, of all of the list of things that are going to be around and spread in the school, doesn't even make the top 20 list. In this case, there was one. We've identified it. We're properly exploring the chance of it. There were other children exposed. Based on that information, we will then know more than we do now.
So it's just a matter of waiting.
Yeah, but that's, yeah, I can't speed up. Yes, ma'am.
Do we know how this student was exposed?
I do not. I don't know if there was, I can tell you how, generally, people get exposed through somebody they know, where they're from, and I can't, to be honest with you, no one's talked to me about that.
The thing that I would say is that there's no expectation
expectation that the exposure occurred at school and that's what made the person sick in the first place. It was external to the school.
So it sounds like we know, but we know it's not at the school. I don't know if that's a fair statement.
So my child was tested by her pediatrician yesterday.
Great.
Should I have her retested again on the 17th out of an abundance of caution for?
Did you get one of our letters advising?
I did,
Sure.
I did, but as normal, I went on those parent parents, so I
Absolutely.
restricted the pediatrician. And then number two, since you kind of mentioned it's unusual, and though it was mild, is the person responding to treatment, and is there any risk of the antibiotic resistant TB?
Great question. Obviously, the initiation of treatment is just relatively young. I think at the time, right? I'm not directly involved in the care. We consult in cases and they're with the physicians.
So if it,
It takes a
some reason-
minimum of 2 weeks in most cases to know that the treatment you're working is working. Now, this is complicated by the fact that she didn't have a lot of symptoms. So, one of the first things you can tell with a patient with tuberculosis and the treatment is working is that within 2 or 3 days their fever breaks. They stop coughing or they markedly less. They start gaining. I mean, wow. This, when you don't have a lot, it's harder to measure. So there are fancier ways to test whether the drug or whether the bug has some resistance. But even with those results, we want to know how the person is doing before we feel confident. And I have a tendency, and Jill knows this, that I tend to mix peas and cheese and everybody else together. So don't put too much into my description of they. Somebody else, ma'am.
How do we know when to dismiss symptoms? Because as one parent stated, I mean, we're in the middle of the season, our child might have a mild cough, they go to school and we tell them, you know what, go to school unless they have a fever, they're doing really poorly. So how do we know when to dismiss symptoms or pay attention and get further testing?
Well, I think first off, I would begin, everything you've been doing as a mom and a parent for however many years is the right thing. You know when something's abnormal with your child, different than what you've seen. Tuberculosis in that category, it's not the flu. It's not runny nose. It's not sneezing. People will have, like I said, and again, I'm talking normal because there's going to be some very unusual, but no one can be totally alert to every pain or anything like that persists. And what I think happened here was they went and asked more questions. But what we're dealing with is right now a lot of influenza. And that flu illness comes on quick. It usually has a fever, muscle aches, runny nose. They are miserable. Tuberculosis, if anything, is going to be a little more subtle, but it's going to have a persistent temperature, maybe those night sweats, and generally would go into what we call a chronic continual cough, one that lasts weeks. So those are some of the clues that certainly the doctors are trained to ask questions about when somebody comes in and they're sick. So I would do the same thing as a parent. I would say, you're doing great by your kids. Keep doing that. Be alert if maybe there's something really unusual. But I predict, and Jill gets nervous whenever I make predictions, I do not believe we're going to find a high number of positives on our skin test or our testing And I would be, while anything's possible, it would be very surprising to me that we'd think a second case linked to this one. That would just be very unusual, very surprising to me. But we're going to do everything to try and make sure if it is, we're going to find it. Yes, ma'am. Sure.
Let's just say it is positive, you mentioned something about the drug.
Yeah. Sure. If anyone, if you do a screening test, and we used to do a lot of work physicals, a lot of people going off to college used to have their TB tests and some other things. If that comes back positive, and people are fine and well, but if that test or any test comes back positive, then there is a medicine, the same medicine. The difference is with active disease tuberculosis, you use 4 medicines. If you're just a skin test positive, because there's so many fewer bacteria, your body has really got it locked up. It just needs a little help to wipe it out. So you use one drug. The drug causes some side effects, so any drug can be, it's not a great thing, but we do that routinely. And all doctors do that routinely. That's not an uncommon thing. It's an antibiotic in the same it's not like penicillin, but it's in the same sort of type. For Jill, what's our standard recommendation to our doctors now? For
9 months.
so it would be for a 9-month period.
What are some of the side effects?
There are some shorter courses, but they even have more side effects and toxicity. Yes, I'm sorry.
What are some of the side effects that you're mentioning?
Well, the side effect that we look out for the most, and it doesn't happen a lot, but we generally would test or advise the doctors, is to check a liver test about a month or so on treatment.
Similar to like a cholesterol medicine.
Yeah, yeah. Most of the others, when anybody starts a medication, sometimes they don't feel good until their body gets used to it. So people say they're sick of their stomach, some nausea, vomiting. We're not talking about life-threatening, serious side effects.
So if you take the medicine, then if you test again, is it negative, or how does that work? Or are you just always positive?
Yeah,
You're always
because
positive.
remember, it's demonstrate that your body has encountered it, not that it's there or not. So yes, once sometimes the skin test in particular, you may fade a little bit, but in general, once it's positive, all is positive. So in healthcare, we're in the hospitals, we test nurses annually to determine if there's an exposure. And if we do find one, a lot of times we know where, but it comes back positive. We stop testing them year after year because there's no point.
Is it the same drugs for latent TB as active?
Yes, that's a great, I didn't use that term, but thank you for introducing it. A positive skin test is called latent tuberculosis. Latent just means that it's present but not active. So yes, ma'am.
Is there anyone that you would recommend not take the medicine, like if certain health conditions?
Well, kind of puts, every patient, you ask, those type of questions. So yes, I would probably come up with some scenario that I would be reluctant. They generally wouldn't fit into young, healthy kids.
Right, but we have
people-
family members that may be compromised with their immune systems.
first they have to be, most patients, at least most doctors are pretty aggressive with this. If you have diabetes, if you have a cancer, certainly all the patients that may have been chemotherapy and transplants, they should have been tested on their own. Know it now. That's good medicine. If they're positive, then you have to use what you know about that individual to customize and determine is the risk of treating them or not. But in this case, what we're talking about is we're assuming, and I believe that's true, that the potential for someone at this age to have those conditions, and we'll ask to make sure, is low.